Hello everyone, welcome back. So now we are going to talk about the bone resorption, how a bone resorbs normally, and what are the patterns of various bone resorption. Okay, fine. Bone resorption and its patterns. So from the basics, okay, recap: host response, rankle, okay, osteoblast, synthesis of bone, okay, osteoblast, synthesis of bone, blast, synthesis of bone, osteoclast, resorption of bone. You have any doubts in this? Very basics, right? So osteoblast, synthesis of bone, a cell which is responsible for synthesis of bone. Osteoclast, a cell which is responsible for the resorption of the bone, right? Okay. Now, if we take a look at an osteoblast, okay, an osteoblast, it will have some receptors on its surface, which I'm going to name it as rankle. Okay, an osteoclast similarly will have some receptors on its surface. I'm going to call that as rank. So when rank and rankle are expressed, normally they are not expressed. When they are expressed, that is going to result in bone resorption. So whenever there are factors or mediators that is going to increase the expression of rankle, that is going to result in bone resorption. Okay, now normally do you think that our body will have bone resorption? Do you think that a bone keeps on remodeling? Obviously there will be. So normally the physiological bone resorption and remodeling deposition to maintain the homeostasis, that is called as bone coupling. Okay, so bone coupling is the interdependency of bone formation and bone resorption. So normally this takes place, right? You have any doubts till now? Very good. Okay, now let us see how bone resorption takes place. What initiates this bone resorption? Okay, so let us assume that this is a cell, okay, osteoclast. Okay, an osteoclast, as I said, will have rank receptor, usually not expressed, but sometimes certain factors will initiate or will increase the expression of these rankle. Okay, so whenever there is going to be interaction of rank and rankle, bone resorption takes place. So recap: host previous chapter, host microbial interactions, right? So interleukin 1, interleukin 6, interleukin 8, tumor necrosis factor alpha, all these are bone resorbing factors. Okay, all these are bone resorbing factors, and also they are going to cause resorption of bone by expressing rankle. And also in addition to this, prostaglandins are also going to stimulate the expression of rankle. So once during inflammation, all these pro-inflammatory cytokines are going to get increased, there's going to be expression of rankle. So what will happen is there is going to be attachment of these osteoclast over the bone matrix. Okay, say for example this is bone matrix. Okay, so the osteoclast, after getting attached or after expressing the rankle, interaction between rank and rankle takes place, right? So it goes and attaches to the bone matrix. Okay, so what happens is it goes and attaches to the bone matrix. Okay, Now what will happen is, there's going to be interaction of rank and rankle. This is rank L, this is rank. So there's going to be interaction. There's going to be, once these rank rankle are interacted, stimulation of osteoclast. So there's going to be stimulation of osteoclast. Clast resorption is going to take place. How is, once these osteoclast, after getting stimulated by a lot of factors like interleukin 1, interleukin 6, tumor necrosis factor alpha, all these, what will happen is it'll go and stick over the bone. It'll go and attach itself over the bone. Okay. And it extends some, projections into the bone. Okay. It extends some projections into the bone. Okay. And ensure their firm adhesion. How this adhesion is, it helps to adhere to the osteo, that is a bone, by integrins, alpha 2 beta 1 integrins, and some additions, CSRC. So with the help of these, the osteoclast attaches itself to the, okay, once it attaches itself to the bone, it is going to form projections of the plasma membrane into the bone. Okay, these are all the projections of the plasma membrane into the bone. So I'm going to call this as ruffled border. Okay, so when I see an osteoclast with a ruffled border, it means it is ready to resorb the bone. Okay, so once the osteoclast stimulated, rank rankle interaction, osteoclast attaches itself to the bone. It attaches to the bone by integrins and certain adhesins, and also it extends the plasma membrane into the matrix. Okay, now after extending the projections or the plasma membrane into the bone matrix, what it does is it is going to create an acidic environment. Okay, it is going to create an acidic environment with the help of H plus ATPase enzyme. Okay, with the help of H plus ATPase pump. Okay, so what will happen is there is going to be increased production of HCO3 minus carbonate ions. So what happens, there is going to be increased acid production, increased acidic environment. So what does this acidic environment is going to do is it is going to eat the hydroxyapatite crystals of the bone, that is going to result in bone resorption. Okay, so this is how an osteoclast, after getting stimulated, it attaches itself to the bone, and then it extends the cytoplasmic processes, its plasma membrane into the bone matrix, and then it tries to create an acidic environment and destroy and eats the main crystals of the bone matrix, that is hydroxyapatite crystals, and it causes resorption of the bone. This is how an osteoclast resorb the bone. Okay, now there is something called as osteoprointegrin, OPG. OPG is nothing but it is an antagonist to bone resorption. It will prevent the adhesion or the attachment of rankle to rank. In that way, it is going to prevent the bone resorption. Okay, so this is how rankle system works in a very simple way. In case you want to read in depth of it, you can also add anything, you will understand it. Okay, so you be very strong in your basics, you can build over it. So next time when I say there is bone resorption, everything should come into your mind. inflammation, bacteria, PAM, PRR, pro-inflammatory cytokines, osteoclast, ruffled border, acidic environment, destroy the bone. That is how your flow should be. If you can recollect everything, more and more you recollect, that is when your revision will be very strong. Okay, just because you can read or you can understand it by watching one time, it doesn't mean it will stick to your mind forever. Okay, you have to revise, you have to recall it n number of times, as much as you can. Never skip a topic while revision, because that is where you are going to get, you are going to lose your marks, you are going to get forgotten. Okay, so when you are revising, revise each and every word, each and every word, or each and every aspect of the notes you have taken. Don't think that I know this, I'll just skip it, I'll just turn. No, that is where you are going to make mistake. Okay, so when it comes to revision, revise everything. Fine. Now, this is what's the basics of bone resorption osteoclast. Now coming to a few defects. Okay, so normally, if you see, normally the interdental bone should be above the interradicular bone. The interdental bone should be more than the interradicular bone. This is called as the positive architecture. Okay, this is called as the positive architecture. If the interdental bone is less than the height of the interradicular bone, as you can see here, see, the interdental bone is somewhere here, the interradicular bone is here. So the interradicular bone is definitely higher than the interdental bone, so that becomes negative architecture. Negative architecture predominantly seen in food impaction cases. Okay, so positive architecture, if the interdental bone is above the interradicular bone. Negative architecture, if the interdental bone is less than the interradicular bone. Fine. Now, if the interdental bone and interradicular bone are at the same level, then that is called as flat architecture. Okay, fine, excellent. Now the first pattern is negative architecture. The second one, what we are going to see is, see, what is a vertical defect and what is an horizontal defect. See, vertical defect is if there is a bone loss in oblique direction. What does that mean, sir? Say for example, this is your tooth. Okay, this is your tooth, you are having bone from here. Okay, so if you are having an oblique type of bone loss, which means your bone loss will be like this, that becomes a vertical defect or an angular defect. Or you are having bone here, you are having bone loss perpendicular to the tooth like this, so equally in all the directions, that becomes horizontal defect. Okay, so vertical defect is bone loss occurring in oblique directions. Okay, and horizontal defect is a bone loss occurring perpendicular to the tooth equally in all the directions. Okay, a vertical defect or an angular defect is capable, or it is potentially capable to of regeneration, whereas an horizontal defect, it is very difficult, or it can, or in other words, you cannot regenerate it. Okay, now what is this defect? This is nothing but, I can see vertical defect here. Okay, it not only involves the mesial aspect of the tooth, it also involves the buccal aspect. So when a vertical defect, okay, when a vertical defect extends to two or more surfaces, it is called as circumferential defects. It is called as circumferential defect. Okay, so when a vertical or angular bone loss involves more than one or two surfaces that becomes circumferential defect. Isn't it amazing, right? Now I'll tell you another beautiful fact about the vertical and the horizontal bone loss. Okay, see, the vertical, the horizontal bone loss, it doesn't occur only in specific diseases. See, you might have read that in trauma from occlusion there will be angular bone loss, in aggressive periodontitis there will be a angular bone loss, but in our chronic periodontitis horizontal bone loss. But see, according to me, that is not true. Okay, let me tell you why. Every bacteria will have certain radius of action. What do you mean by radius of action? Radius of action means that is the upper limit until the bacteria can attack, which means I'm standing here, I can stretch my hand to maximum level I want, but above that, if some person is standing, I cannot beat them, right? So that is a maximum limit. I can stretch my hand, I can beat a person. Similarly, a bacteria cannot destroy the bone or the tissue if it is more than 2.5 mm. So the radius of action is 1.5 to 2.5 mm. If it is more than 2.5 mm, your bacteria cannot destroy it. Now you just imagine my posterior tooth. Most of the times the posterior tooth will have a broader interdental bone, right? Brilliant. You guys are amazing in imaginary powers, right? So see, say for example there is an interdental bone here. Okay, this is my posterior, I'm having interdental bone. Let us assume that it is 4 mm. The interdental bone is 4 mm. Now you use your common sense and tell me what type of bone loss can I expect here? Considering the radius of action in your mind, just use and tell me that what kind of bone loss I can expect. Exactly. There will be only vertical or angular bone loss because a bacteria can extend only 2.5 to 1.5 to 2.5 mm. It will just destroy till here, right? So this entire aspect will be destroyed. So your bone will look something like this, isn't it? This is what we call it as vertical defect. So vertical or horizontal bone loss depends upon the thickness of the interdental bone rather than the disease per se. Because you take a look at the lower anteriors, it is going to have not that much amount of big interdental bone as compared to the posterior. So obviously I can expect horizontal bone loss, right? So very difficult to expect an angular bone loss in case of lower anteriors because the interdental bone will be very thin. So it will be, within the radius of action. So most of the times the bacteria will destroy the entire bone, so that is going to result in horizontal bone loss. Okay, fine. Now coming to the next defect. In this defect you see there is presence of, so this defect you see there is going to be presence of, just a minute. Okay, now this defect, if you see, I'm having buccal wall. Okay, I'm having palatal or lingual wall. Since it is lower, let us consider as lingual wall. So I'm having buccal wall, I'm having lingual wall. What I'm not having is the interdental portion. So there is a small dip in the interdental portion. So my buccal and the lingual wall are here, and in between I have a small dip and then it comes out. Okay, this is called as osseous craters. This is called as osseous craters. So osseous craters are very important because they make 1/3 of the total defects, which is around 35 percentage, 32 to 35 percentage, and 2/3 of the mandibular defects, which counts to about 62 percentage. Okay, so osseous craters are nothing but they are depressions in the interdental bone which is bordered by the buccal and the lingual walls. Okay, so it's very important because it accounts to one third of the total defects and two-third of the mandibular defects. Fine. So the next one what you're going to see is, this is a picture of lower anteriors, as I told. So there is a horizontal bone loss. There's equal destruction of bone at all directions. Okay, this signifies it is an horizontal bone loss. Very good. So this image, it depicts some kind of a wall defect. Okay, as you can see here, all the walls are present except the buccal wall. Buccal wall is slightly destroyed, right? You take a look at this picture again. Buccal wall is destroyed. You take a look at this picture. Buccal wall is present. Interdental wall is destroyed. One interdental wall. It's especially if you take a look at, if you can consider canine, the mesial wall of the canine is destroyed. The distal wall is safe, right? So this kind of cases where all the three walls are present and only one wall is destroyed, right? Only one wall is destroyed. This is called as the one or two or three wall defects. So see, cut